Hello guys and welcome to this video about how to approach acute pancreatitis in emergency settings. So in this video I'm going first to give you a definition to this condition, and then I'm going to talk about how the patient is presenting to you, and finally I'm going to talk about the diagnosis and treatment of this condition. So acute pancreatitis is inflammation of the pancreas, and this is usually caused by activation of pancreatic enzymes and autodigestion. The etiology is usually by overstimulation of the pancreas, and this happens in alcoholic patients and in high dietary fat intake, because this needs a lot of pancreatic juice to digest. The other etiology is the duct obstruction, and the obstruction of pancreatic duct leads to interstitial edema and impaired blood flow and acinar cell injury and activation of enzymes and autodigestion. And duct obstruction is caused by gallstones or sickle cell disease or cystic fibrosis. Maybe it is caused by anatomical anomalies like choledochal cysts and pancreatic divism. But mostly it's caused by gallstones, most commonly. Maybe there's direct cell acinar cells injury and releases of proenzymes and further injury and activation of enzymes, those enzymes which leads to autodigestion. And this is caused mostly by alcohol, but may be caused by drugs like azathioprine, hydrochlorothiazide, or bentamidine, or may be caused by trauma, ischemia, hypertriglyceridemia, hypercalcemia, hyperthyroidism, or may be caused by infections. Maybe acute pancreatitis is caused by defective intracellular transport and intracellular activation of enzymes, which leads to acinar cell injury and autodigestion. And this is caused by alcohol or duct obstruction, also might cause this. In severe acute pancreatitis, which, like most of the pancreatic attacks, are usually mild disease, but sometimes it might be severe acute pancreatitis. So there is release of cytokines, toxic enzymes, and mediators into the circulation, and activation of systemic inflammatory response, and this leads to uh, leukocytosis, DIC, disseminated intravascular coagulation, acute respiratory distress syndrome, hemolysis, peripheral vascular collapse, and shock. And this is considered a medical emergency, and it needs treatment very quickly. Now, for the patient presentation, this is the history part. So, the main symptom in acute pancreatitis, is the pain, and it is an epigastric pain with radiation to the back, and it is severe pain and aggravated by meals. There might be also nausea, vomiting, anorexia, and low-grade fever. Now for the examination part, there is usually abdominal distension in the epigastric region and epigastric tenderness, and there might be palpable abdominal mass if pseudocyst is developed. Decreased bowel sounds, there might be jaundice if the cause is gallstone pancreatitis, or if the pseudocyst is compressing the common bile duct. Also, tachycardia is usually present if because of pain and dehydration. Hypotension is usually because of the dehydration or sepsis because of infection. Colon sign is discoloration of the umbilical region, and the gray Turner's sign is discoloration of the flanks. And those signs appear in the severe disease, which is accompanied uh, by hemoperitoneum, which is hemorrhage into the peritoneal cavity. Now, for the diagnosis uh, is by the laboratory studies and the imaging. The laboratory studies, uh, you need to order serum lipase and serum amylase. The lipase is usually more specific than the amylase because the amylase is secreted in the renal failure, and it's also secreted from the salivary glands. So it is not very specific like the lipase. The lipase is elevated within 4 to 8 hours and peaks in 24 hours and remains elevated for 1 to 2 weeks. Liver function test, if elevated, this indicates gallstone pancreatitis. Renal function test, also. Blood glucose, if elevated, this means there is damage to the Langerhans cells. The calcium level, if decreased, this means that the calcium is being there's sequestration of the calcium in the fat necrosis of the pancreas. The complete blood count, you might find leukocytosis in lipid profile. Uh, this is you might find hypertriglyceridemia, serum LDH. Also, you should order this, and C-reactive protein also. For the imaging, you should order abdominal X-rays and chest X-rays. To for chest X-rays for the pleural effusion and for the acute respiratory distress syndrome, which is caused by those the enzymes from the pancreas are being secreted into the the bloodstream, and those are uh, uh, going to the lungs, and they are damaging the alveoli and causing ARDS or pleural effusion, maybe. The CT scan is useful for complications and also useful if you are not sure of your diagnosis. The ERCP reserved for therapeutic interventions, and MRCP is used for the diagnosis of the causes. Now I want to talk about the Ranson's criteria. This is used to predict the prognosis of acute pancreatitis, and it is uh, on 2 occasions at admission of the patient and during 48 hours. So at admission, the age, if the patient age is more than 55 years, the patient gets 1 point. The white blood count, if it is more than 16,000, this is another point. The glucose, if it is more than 200, uh, also gives 1 point. The LDH, if it is more than 350, also 1 point. The AST is more than 250 also. And during 48 hours of the admission, the hematocrit, if the hematocrit fall by 10%, the patient get 1 point. And the blood urea nitrogen, if it is more than 5, also 1 point. The PaO2, if it is less than 60, indicate 1 point. And base deficit, if it is more than 5, also gives 1 point, and serum calcium, and if it is less than 2, gives 1 point, and finally fluid sequestration, if it is more than 6 platters, also gives 1 point. Now for the interpretation of this criteria, so if the score is a 3 or more, this indicate severe acute pancreatitis, and and also this score also predict the mortality. If it is less than 3, then the mortality is less than 1%. If it is from 3 to 4, it is 15%. If it is 5 to 6, it is 40%. And if it is more than 6, it is 100%. So for uh, the treatment consists of the bowel rest, nothing by mouth, and uh, you restart the feeding after resolution. That's for the milder cases. But if there is severe inflammation, severe acute pancreatitis, and you assess it with Ranson criteria, it indicates severe acute pancreatitis or any other criteria, you should induce early enteral feeding because patient need nutritional support, and acute pancreatitis is usually not going to resolve in a week, and so you need to induce this feeding very early so your patient uh, is going to be uh, have more chance to survive. Uh, Also, you should give IV fluids. The regular lactate is preferred over the normal saline unless hypercalcemia is the cause of acute pancreatitis. In case regular lactate is going to make it worse. And for the first 24 hours, you should give from 2,500 to 4,000 milliliters total, and then you give accordingly. Analgesia, you start with acetaminophen. If mild pain, and if severe pain, you should change to tramadol and meperidine. Antibiotics, you should cover the enteric anaerobic and aerobic microorganisms, and this is usually achieved by imipenem, ampicillin, and ceftriaxone. You can use any other antibiotics that cover the enteric anaerobic and aerobic microorganisms, and also follow the local guides because every hospital have different uh, antibiotics types. So you should check your local guidance for this. ERCP for gallstone pancreatitis and range of infected pancreatic collection. And the surgical option is the necrosectomy. The complications, the local complications is necrosis because of inflammation. Pseudocyst, pancreatic abscess, those are because of the disruption of the pancreatic duct. There might be systemic complications like ARDS, which are microthrombi in the pulmonary vessels, hypocalcemia because of sequestration of calcium in fat necrosis, hyperglycemia because of disruption of islets of Langerhans, and there might be shock and dehydration, and disseminated intravascular coagulation might be present. The GIT complications, the GIT bleeding because of the erosions into the gastric or duodenal structures because of the pancreatic enzymes, or jaundice. This is usually because of the compression of the pseudocyst to the common bile duct or because of the gallstone pancreatitis. Thank you guys for watching. Make sure to like this video and subscribe, and also comment down below your suggestions for the next videos.